Okay, so it's 10:31 or so by my watch. I think we are going to go ahead and get started. Dr. Weber's here somewhere. So okay. Okay. Move some things around. And I'll wait for a few people to get in and get seated. Okay. All right, so we can get this party started. Okay. Good morning, everyone. My name is Rhonda Smith. I'm the Executive Director of the California Black Health Network. Thank you all for coming today. We really appreciate it. This is the first congressional or legislative briefing that we've had, at least in my tenure over the last 5 years with the California Black Health Network. And I want to thank some important people that helped us get here today. First of all, my staff and volunteers who have been working tirelessly behind the scenes to make sure that everything is right for you when you arrive today and while you're here. I also want to thank our sponsors. That's the Alliance of Catholic Healthcare, Dignity, as well as Providence. We've been working together for over a year or so now, and we really appreciate their partnership and support to make this event happen today. We also have a Health Equity Summit coming up in October, but the Alliance and its member organizations have really been working to serve vulnerable communities for over 160 years here in California through special innovative programs that address food insecurity, maternal health, rural areas, homelessness, you name it. There's so many things that they do here across the state for our community. So we're very proud to be able to partner with them and bring this event to you today. And so just a little bit about what we're going to be doing today. So this week is actually Black Breastfeeding Week, and when we were thinking about when to host this event, we intentionally chose this week. And we know that the data shows that Black women often do breastfeeding a lot less than white women do, and that disparity is not related to anything by choice. It is due to structural and systemic issues that create inequities in terms of access to the resources and support that they need to be able to do that. And so we know that that's just one of many disparities that Black women face and other women of color face when it comes to maternal health outcomes. We'll talk a lot about that today. We'll hear from some amazing, incredible women who are doing amazing work here in the state. We'll hear from experts in the public health space, in community advocacy, research, as well as hospital or systems related activities. And so I don't want to belabor the point. I'm really excited to hear what everybody has to say today. And I think Dr. Weber is here and ready. Yes, okay, so before we get started with the panel, I would like to introduce Dr. Akilah Weber. Most of you know her. She will say a few words today about Black maternal health. I was going to say do an introduction, but I think most of you really know who she is and know about her background, so I just won't say much. I'll let you say whatever you want to say, and thank you so much for being here.
Good morning, everyone. Good morning.
Good morning.
All right. I was just mentioning I was outside because I got paged about a patient, so it's like perfect timing to put me back into my doctor mode. But I want to thank you so much for the honor of opening this event, and also for California Black Health Network for hosting this very, very critical discussion. As was stated, my name is Dr. Akilah Weber Pierson. I am the California State Senator for the 39th Senate District, proudly representing parts of San Diego County. I also serve as chair of the California Legislative Black Caucus, and I am also a board-certified practicing OBGYN. So today, we come together to emphasize the importance of advancing high quality and robust health care for Black women across the state. We as Black women deserve equitable care to repair past damages that have caused generations of pain, and we need policy and advocacy efforts to lead that change. You may hear what I am now getting ready to emphasize multiple times throughout this event, but it is necessary to echo the gravity of this critical topic. Here in California, we tragically lose another mother due to pregnancy-related complications every 5 days. Here and nationally, Black mothers are 3 to 4 times likely to be one of those mothers lost, accounting for 40% of maternal deaths. During one of the most sensitive and significant moments in one's lifetime, the blessing of bringing life into this world cost too many Black women their own life. And it has been said that if we sit by idly, this maternal mortality rate could nearly double by 2040. There is a very popular and very, very dangerous narrative filled with discriminatory rhetoric that almost suggests that we should place the blame on Black women for these staggering statistics. The US has still one of the highest mortality rates among high-income nations, even after adjusting for education and income. And this is because of persistent racial disparities. And 80% of those deaths are considered preventable. Simply because not enough policymakers, especially in the federal administration right now, have the courage and the power to make impactful change and proudly value Black women and Black families. I would also be remiss if I only focused on maternal mortality outcomes. Pregnancy and childbirth can take a devastating toll on the mother, the infant, the family, and the community as a whole. For the mother, the most immediate and likely consequence of childbirth is not death, but disability. Conditions only present in perinatal health, including eclampsia and gestational diabetes, can cause long-term neurologic and cardiovascular harm, leading to significant loss of healthy working years due to disability directly connected to pregnancy or childbirth. Black infants in the US are more than twice as likely to have low birth weight, be born prematurely, and have developmental challenges or die by their first birthday. In utero exposure to conditions such as preeclampsia and other maternal hypertension conditions are linked to long-term cardiovascular conditions in these children. Families are forced to endure the preventable loss of life of their mother, their wife, their sister, and its associated traumas. Communities fill the void when they lose pillars of their village. And it is difficult for the village's need for a child while still navigating the loss of the village's rightful center. And despite all of these factors, it is very clear that this federal administration wants to make this grim reality much worse. Federal cuts threaten access to culturally affirming perinatal and family planning care, severing lifelines for Black women, especially in underserved areas. In California, $28 billion in Medicaid funding is at stake, risking care for 3.4 million people. The million-dollar question is, what do we do now? It may feel like a challenge too big to solve, but that is exactly what those who gut healthcare and devalue families want us to believe. The path to equitable care will not be easy, but we must be creative and focused in our advocacy by bringing everyone to the table, patients, doctors, policymakers, health plans, facilities, researchers, and even technology developers and users. We also need approaches that are centered in efforts that are not specifically focused on pregnancy itself. I speak of this all the time, but we must focus on improving the social determinants of health, all of the surrounding conditions that shape health outcomes long before, during, and even after a mother enters a delivery room. This means addressing access to safe and stable housing, reliable transportation to appointment, nutritious foods, clean air and water, and economic opportunities that allow for families and individuals to thrive. When these needs are unmet, health risks are magnified and disparities deepen. Strengthening our social determinant of health plays a big role in improving health from preconception through postpartum, increasing Black representation in clinical trials, fostering trust in the healthcare system, and making California a safe space for childbirth. Addressing these persistent disparities could save thousands of lives, save hundreds of millions of dollars in healthcare costs annually, and reduce the amount of preventable maternal deaths from 80% to 0%. Ensuring high-quality, equitable care must be a priority in maternal and women's health efforts in California and across this country. In all, we must care for, protect, and invest in Black women. Because when we do that, we are investing in all women, we are investing in all families, and we are investing in all of our communities. This looks like centering the voices, reducing barriers to timely care, and scaling creative models that address wrap-around care beyond just the delivery room. There is no silver bullet, but I trust leaders in this space to fight for this justice. I want to thank you again for this opportunity to participate in this critical discussion. I look forward to seeing what comes out of it. I want to thank you all for your continued efforts and progress and support and your love, and most importantly, your focus and your advocacy on Black women. Thank you so very much and have an amazing day.
So thank you, Dr. Weber Pierson. We really appreciate you taking time out of your busy schedule to be here today. And so we have, as I mentioned earlier, some incredible women who are going to share stories about women in the community across the state and some of the disparities that they face. We'll hear some research about what's happening with Black women, because despite the progress that we've made here in California and despite the legislation that has been passed over the past 4 years, Black women are 3 to 4 times more likely still to die during their childbirth experience. And so hopefully we can come up with some solutions to change that trajectory, despite what is happening at the federal level and how that will impact California. And so I will call each of them up and we'll talk about some important information today. So first, Brittany Chambers, who is the Associate Professor of Department of Human Ecology at UC Davis, Dr. Pallav Barbaria. She is with the Department of Healthcare Services here in California. She's the Chief Quality and Medical Officer. Dr. Zaya Malawa, who is the Director of Expecting Justice and the Abundant Birth Project. And then Sandra Poole, who is the Health Policy Advocate and Lobbyist at the Western Center on Law and Poverty. And last but certainly not least is Adwa Jones, who's here from Los Angeles. And she is the Chief of the Birth Equity Unit and Director of the African American Infant and Maternal Mortality, otherwise known as AIM, Prevention Initiative Program in Los Angeles. And so I'll turn it over to Dr. Chambers to actually begin the program, and I need to make sure that everything is set and ready for you to go. Yes.
Okay, good morning, everyone. I'm super excited to be here today and to sit on this panel with these amazing women. I will be sharing some data about the state of Black maternal health in California and share a little bit of my research around moving towards evidence-based solutions. I have no interest to disclose this morning. So if y'all do not know about it, y'all need to get to know about this amazing report that was developed with Black women in the Black orgs, some who are sitting on the panel today, as well as Black scholars highlighting and centering Black mothers in California. So I will be presenting data from this report, and I'm doing this as a way to encourage you all to use it as you continue to report data around your cities, the state, and the country. But here, when we look at it, we see that Black women and birthing people represent about 6.5% of the birthing population. And so we want to keep this in mind when we think about the disparities that we are about to show. So before entering pregnancy, due to exposure to structural racism across their life course, which contributes to a wear and tear on the body, Black women come to pregnancy with comorbidities. So we see here, if you look at the blue bar, these are data for Black women in comparison to Hispanic, Latino, white, and Asian Pacific Islander women. And this often leads to rates of severe maternal morbidity, which is displayed here. And when we just look at this graph, the colors remain the same, where the blue line represents Black women and birthing people. If we look at in comparison to white women and birthing people, they're about 2 times more likely to experience severe maternal morbidity. And just as Dr. Weber Pierson already shared, that when we look at pregnancy-related deaths, that Black women and birthing people are 3 to 4 times more likely to die during birth or from related complications in comparison to white women. And this is for California. We often think that we do not fall within these numbers, but we see that we're leaning more towards the 4 times more likely. And when you look at certain counties, this inequity gap actually increases. And also what was mentioned, 80% of these are preventable, right? And research shows that racism is the root cause of these inequities. We like to call it a racial bias, but it really fits under the umbrella of racism. And we have been doing a lot in California to really address this. And what I mean by we, I'm saying Black orgs, Black organizations, as long as our allies who are in this work with us as well. So if you are not familiar, there are 2 policies that have been implemented related to this that started in 2019 with SB 464, targeting perinatal care providers. It really called for implicit bias trainings as well as tracking maternal deaths and related complications on a consistent basis and in a uniformed way. Most recently, this has extended to include more people on the healthcare team, recognizing that it's not just providers or clinicians that people experience discrimination to. And then also it added some proof of compliance. We saw the report from the Department of Justice showing that a lot of people have not been compliant. And so how do we enforce penalties to make sure that people are doing this, as well as calling for the curriculum to expand and address intersections. So although all of this has been done, there are currently no evidence-based trainings available for perinatal care clinicians to actually take for this bill, to fulfill this bill. And what I mean by evidence-based is that the trainings that are available have not yet tested provider outcomes. And so for the past 6 years, I used a community-based approach to develop the CREATE training, and I'm going to share a little bit of the preliminary findings today. To create this training, I consulted with the Black women as well as prenatal care providers of color to develop the curriculum. It has 5 modules that outlines the overview of racism in the U.S., racism in healthcare settings, Black women's perspectives, as well as clinicians' perspectives and outcomes, and walking clinicians through an action plan and reflection. In here, there are stories, both qualitatively as well in video format, that were collected specifically for this from Black women, as well as stories from clinicians to really see what they wanted in a training, as well as experiences of racism that they navigate in. And then briefly, among the 36 people who participated, we saw significant increases in people's reported knowledge around racism and understanding it as the root cause of disparities. We also saw an increase in people's confidence to address racism, racial justice, and equity within their healthcare teams. We did not see any changes in people's internal and external motivations to respond in non-prejudiced ways to Black birthing people. And we didn't see any changes in providers' implicit bias, although the data showed here is hinting that people are leaning more towards having a slight preference towards Black people. And this concludes the data that I'll be sharing with you all today. And I'm really, really excited to hear how the other panelists are going to add on to this work.
Thank you so much, Dr. Chambers. Hi, everyone. I am here today on behalf of the California Department of Healthcare Services, which I think everyone knows runs our state Medi-Cal program, which currently covers 14 million people, soon to be less because of the devastating federal changes happening right now. But in the midst of these really trying times, I do think our department's work on the birthing care pathway is something that gives me hope about what we can accomplish in our state, and includes a lot of work that is largely protected from some of those federal changes that are coming. And my job at DHCS is really to ensure quality and equity for our 14 million members in all domains. So you all probably know this, but to double click on some of those figures that Dr. Chambers was sharing with us, within Medi-Cal, we cover about 11% of all births that happen nationwide. So 1 in 10 of all births that happen nationwide occur in California. So what happens here is a huge driver of those national statistics. Within our state, 40% of our births are on the Medi-Cal program. 72% of those births happen in a Medi-Cal managed care plan. So I think many of you have probably been tracking CalAIM and a lot of the Medi-Cal transformation work that's happening. We have shifted most of our population into managed care, and that is true of all of the pregnancy and postpartum care as well. And so as we think about how do we fix these problems, how do we get to the root cause, the managed care plans are a key driver in that future. And we know that there's deep disparities. So within the Medi-Cal program, we also see that same 3-to-1 mortality ratio that is really borne on the backs of Black women, as well as Pacific Islanders and Native populations. And then we also see the intersectionality. So, this is pulled from that same database of our California statistics. So when you look at this, if you are on Medi-Cal, you are 2.8 times as likely to die because of pregnancy-related causes than if you have private insurance. And we know that people who are Black and pregnant in our state are also disproportionately likely to be covered by Medi-Cal. So what are we doing about it, right? These statistics are not new. We've seen them. We have known about them for a very long time. And a lot of the work we've been trying to do at Medi-Cal is creating a multi-pronged strategy to actually move the needle to implement those evidence-based practices. And so in 2022, we launched our Bold Goals 50 by 2025 campaign. This was submitted in our comprehensive quality strategy. It was submitted to the federal government. And we committed that by the end of 2025, we want to close maternity care disparities for Black and Native American persons in our program on Medi-Cal by 50%. We are looking at prenatal and postpartum care and C-section rates to monitor that. As we started to dig into, okay, how are we going to do this, right? What is wrong? What's broken here? It became really clear that it wasn't one or two policy fixes. We really needed to overhaul our entire maternity program. And I think people know Medi-Cal has covered pregnant individuals for a very long time. And so we have a lot of old policy. And as we started looking under the hood and understanding what's broken, what needs to be updated, it kind of snowballed into everything. And I will tell you, as a mother of two, our lactation policy was written in the 1990s and had not been updated since. Anyone who's given birth, breastfed their kids, or pumped knows that the technology and knowledge around lactation a little bit different today than it was in the 1990s. And our policy and our coverage, you heard Dr. Weber talking about the breastfeeding, and Rhonda talking about the breastfeeding disparities. Our coverage hasn't kept up with that, and our policy hasn't kept up with those changes. And then that instills disparities in the services that we provide to Medi-Cal members. So we wanted to back up and say, okay, how do we fix this? Soup to nuts. Let's look at all of our policies. But we also knew we don't have all the answers, right, as state policymakers and regulators, and we really needed to listen to our members and prioritize their needs. And so we launched the birth and care pathway. It took us about 2 years, honestly, to do this. We did tons of meetings with providers, with doulas, with midwives, with everyone working in the social services sector, WIC, SNAP benefits. And most importantly, we really incorporated members in our policy design. And so the Birth and Care Pathway report, I think many of you are tracking, was published last February. It is a comprehensive report that includes all of our findings. There's 42 policies in there that DHCS has committed to implementing. And they were really centered in the member engagement and focus groups that we held. And I think that's really where I want to double down. So we recruited Medi-Cal members to do focus groups with us and to do journaling longitudinally to tell us how their experience on Medi-Cal changed through the course of their pregnancy. And we got overwhelming interest. We had 400 members who wanted to participate. We were grant funded, so we only had funding to involve 30 of them. But these are the 6 themes that they really shared. And you'll see a lot of it is very resonant with other reports that have been done on the state. But feeling respected and heard in their care delivery is not happening and is the #1 need. We had countless examples of discrimination in their healthcare encounters and how having a diverse workforce and racially concordant care really improved their experience. And we know that our system has lots of gaps, and they're not necessarily intentional, but time and time again, services, referrals, follow-up that needed to happen didn't happen. We also learned that we have a lot of programs in California, right? The problem is not always the programs. It's just that none of them talk to each other, and it's a full-time job for our members to go to the 30 different appointments and programs and services they need. And who can do that with a newborn baby at home, right? Mental health continues to be a major challenge, and finding providers who can really serve pregnant and postpartum individuals with their mental health needs is a huge gap. And that we've done all this work to expand benefits, right? Medi-Cal pays for CHWs, for doulas, for community supports, for ECM, and most of the members in our work groups, no idea that those were benefits and that they were entitled to those services. And so I will just close with, the 42 policies we're doing, I think, are great. We are modernizing Medi-Cal policy, some of which is really old and dusty, and it will set a high bar in expectations. But I have no pretenses that that policy change is going to solve all these problems, because what we really need is an overhaul of how we think about maternity care, how we structure our programs, how we integrate them, and to really take the onus off of individual people and really make our systems work for them if we're going to close these gaps.
You're here. Hi, everyone. I'm Zaya Malawa. I'm a pediatrician and a public health professional based out of the Bay Area, but I do work statewide. Oh, yay. And I'm so pleased to talk to you all, excuse me, about addressing our racial disparities here. Sorry, I'm not sick. I think I have an allergy to authoritarianism. Okay, so first I just kind of want to start with one of my favorite studies that came out recently. The March of Dimes convened a panel a few years ago of multidisciplinary experts to kind of understand what is causing the black-white disparities in preterm birth. And so they were, I told you all of these things already. They looked at 33 hypothesized causes and really looked at the evidence around these. And here's what they found. They found in 2021 that racism is the only factor identified that could directly or indirectly explain the racial disparities in the plausible midstream and downstream causes. And then it goes on, and I love this graph, to really break it down for us. And so we start with these upstream causes, systemic and structural racism. And so these are things like the unfair systems and structures, laws and policies, entrenched beliefs that are advantaging some and disadvantaging others according to their race. But this, of course, leads to unfair treatment. We see this unfair treatment as economic disadvantage, environmental injustice, mass incarceration, voter disenfranchisement, and institutionalized racism in a number of institutional spaces. This, in turn, leads to health-harming exposures, and they found evidence of this is in things like chronic stress, which is a big one. Chronic stress is one of the most toxic things that can happen to a pregnancy, but also toxic exposures, hypertension, gestational diabetes, all of these kind of downstream causes that we know are impacting Black folks disproportionately, since Dr. Chambers just pointed that out. And then that gets us down to some of these biological mechanisms. How are these structures kind of getting under our skin and making us sick? It's through inflammation, it's through changes in our immune system, it's through vascular effects, and all of this ultimately leads to preterm birth. And so I think when we're trying to think about these disparities from a more structural perspective, what can we do to break the chain kind of on the more upstream side of this chain of causality? And so if we look at this chain, one of the things that, I didn't know that Brittany Chambers was going to mention this, but one of the things that we did in California, of course, is pass SB 464, which is the California Dignity in Childbirth Act, and it requires that we do this racial justice training for healthcare providers. And I'm saying racial justice training as opposed to implicit bias training because implicit bias was a part of it, but also it required providers to look at kind of power dynamics within the United States and within the hospital space and other things that are important for racial consciousness. Some of the challenges that we had with implementation of SB 464 is that it was difficult to track if hospitals had actually completed the trainings. There were few consequences if the hospitals failed to complete the trainings, and there was real variability in the quality of the training provided. And so we came back with another bill that was signed into law in 2024, and this requires all perinatal providers, not just folks in the hospital and not just doctors, to complete the training. This is really important because it wasn't just physicians. I mean, we definitely have problems as physicians. I don't want to let us off the hook. But it wasn't just physicians that are really implementing racism in the medical spaces. And so what does it look like to touch all perinatal providers, including outpatient providers? It also requires that everyone have completed this training by June 1st, 2025. So for all of those laggards who hadn't gotten it together when the law was initially passed, this is the final time, and then they have to show proof every 2 years thereafter. And it gives the Attorney General the power to actually enforce this through civil penalties, and all hospitals actually have to submit proof of compliance. So this is kind of how we amended it. But the challenge is still is this, and I think, again, Dr. Chambers was alluding to this. When we are counting on trainings to be the thing that fixes provider behavior in medical spaces, we're kind of going with this like train and hope approach. And so that kind of means that we're relying on the internal motivation of the providers, who you can imagine are super busy. I mean, we are really, really busy, feel a lot of pressure, but also a lot of providers kind of don't like being questioned, especially about something as important as racism. I mean, honestly, in California, people would rather be called like an a-hole than a racist, right? And so for providers to actually have to own that they might need to make changes is really hard. And if they don't have that internal motivation, then the training's not going to help. Relatedly, it's unclear if these trainings are having the desired impact on providers or patients. We're just kind of hoping that they are. And then lastly, it's difficult to create accountability for hospitals that have gone through these trainings but are still being racist, right? So these are some of the challenges. And so what I like when I think about training is going from a train and hope to a train and measure type of approach. And so that can look like this would allow everyone to assess the impact of the training so that we can actually know, did this training make a difference for providers or patients? And if not, where do we need to adjust? Also, it can create accountability for facilities so that it's not just stopping at, okay, we've trained everybody and they have this knowledge, but how do we actually get people to change their behavior? And I will just say, it is so hard to get providers to change our behavior. I mean, sometimes a study will come out that says, hey, this old cheap drug is like the best drug for hypertension. And then it takes like 20 years to get doctors on board with prescribing like the most effective drug. The way how we actually get this done in the medical field actually is we create accountability that's oftentimes tied to our performance review as providers. Like in Kaiser, if you're out there providing antibiotics for viruses, you're gonna have a problem when it comes time for your review. So we need to have some kind of measuring and accountability for providers so that if you have done this training, but you're still acting wild in the clinical space, it causes you a problem and not just the patient a problem. And then lastly, if we're measuring everybody, then it can help patients decide where they actually want to give birth and who's actually doing the work to make it safe for folks who experience marginalization. Okay, but going back to this chain of causality, another idea in addition to these trainings could be just giving pregnant people cash, which is kind of what I'm all about. And so if we were giving pregnant people cash, we could interrupt this chain in multiple spaces. For one thing, we could break this chain in between health-harming exposures and then actually having a biological effect from this. So this could look like, for instance, if you cannot have a healthy place to exercise, or you cannot afford healthy food, if you have some extra cash, now you can eat nutritiously. Now you can get the exercise you need in order to prevent things like diabetes and hypertension. If we give cash, we can also interrupt kind of in this mid-phase because, for instance, let's say you are trapped in inadequate housing that is causing you to have asthma because there's too much cockroach exposure. Or let's say that you are experiencing unfair treatment at work that's preventing you from getting a promotion at work. When we give you cash, we're allowing you to not necessarily have to experience the harm of that unfair treatment because you have the cash to be able to move in ways that you know will be healthiest for you and not just the ways that are accessible at your income level. And then lastly, when we give cash, we can actually start to break the chain between the experiencing of structural racism and the impact in certain dimensions. One of the key impacts of racism in this country is extraction of resources from marginalized communities. And as a result, many Black people have been alienated from the economic ladders that are available to other people in California. And so when we give cash, we are infusing economic ability and economic opportunity into this group that has experienced marginalization. And not only are we infusing opportunity, but we're also infusing autonomy, letting folks have the dignity of being able to know what's best for them and then choose it accordingly. And so that is exactly what we've been doing with the Abundant Birth Project, which is a guaranteed income program here in California. It provides unconditional cash during pregnancy and the postpartum period. We started in San Francisco back in 2021, and we have since expanded to 4 other counties across California. And our program provides 12 months of payment and abundance coaching. And I'll say, since Adjoa is on the panel, in Los Angeles, they were able to raise more money, so they actually get 18 months of cash in Los Angeles. And we were the first of our kind in the United States, but we were far from the last. As of last count, I think there are more than 25 programs across the country that give cash in the perinatal period. In case you were wondering, why cash during pregnancy? Well, one thing that was really amazing is that Canada has been giving cash during pregnancy since the early 2000s. They didn't have to do all this research. They just knew that it makes sense to not let pregnant people be ridiculously poor during this critical window. And then finally, after 20 years of Canada giving out this cash, they decided to study it. And they found that a relatively modest increase in income reduced preterm birth by 17.5%, reduced low birth weight by 21%. These are insane numbers. I mean, like, these are like Ozempic level numbers. I mean, I would be like a rich tycoon if cash were like a prescription drug that I made people buy. So in San Francisco, we were able to reach 151 moms, 154 abundant babies. In January of 2024, we spread statewide. And so this is how much money we're offering in each of our counties to these mamas. And basically what we wanted to do is we used the measure of the cost of living in each county to decide how much money we will be providing in each county. So we wanted to kind of proportionalize it based on the cost of living so that this could be a sustainable system in the state. In case you were curious, and I know I'm almost out of time, so I'm going to hurry through this, bear with me, but these are the eligibility criteria. So you have to live in one of our counties, you have to be in the first 2 trimesters, you have to be over 15 years of age, you have to meet the income requirements, which were decided by community, but again are based on the cost of living in each county. And community really wanted to include middle-class folks too, and so in general, the income requirements are significantly above federal poverty level. And then you have to meet one of these top 5 risk factors for birth, and these are they. And so you can see here that similar to how the birthing population of focus is working for ECM, we are using racial and non-racial categories as a way to stay within the law, but still do racial targeting towards the people who need this support the most. Okay, and so this is where we're at now. We have served over 1,000 participants. We've given out $8.5 million so far and counting. We've had 520 abundant babies born. I personally have held 7 of them. It was amazing. And then I'm going to end here. This is a quote from one of our LA participants. She said, "I'm having the healthiest pregnancy after suffering a stillbirth. I'm getting my rainbow baby any day now. And it's all because ABP, that's Abundant Birth Project, helped me eliminate so much stress with the guaranteed income every month." So thank you. If any of y'all want to do some upstream legislation, this is my email. I am all about it. You can ask Senator Skinner's office because we got down on the California omnibus bill, so you just let me know, and I am here for it. All right, thank you.
Good morning. Again, I'm Sandra Poole. I'm a health policy advocate at Western Center on Law and Poverty. And through the lens of economic and racial justice, Western Center educates, litigates, and advocates around areas of housing, health, public benefits, and justice. Over the last couple of years, our health team has prioritized Black birthing justice, particularly the disparities in Black maternal care, as one of our priority issues. So I'm just really thankful to CBHN and Rhonda for inviting us to participate in this panel today. Now, I was asked to review legislation that California has passed over the past couple of years in current legislation, and thanks to my esteemed colleagues, here I will be skipping through some of my slides, so just bear with me as we go forward in that. Also, there's been a lot of talk about data. And so rather than go through that again, I'll just make a summary statement that, you know, we're doing a lot of work and there has been some progress made, but unfortunately, just this year in February, the CDC issued a report that showed that the gap between Black and white disparities in maternal mortality is actually increasing. It's getting worse instead of better, and that was also confirmed by a study with the Gender Equity Policy Institute. Again, there's a lot of data out there, but one thing that this data confirms is that there's a lot more that needs to be done. There's no magic solution or a simple approach to solving this very complicated issue. It will take everyone, the legislature, administrative agencies, and community to work together to solve this. I'm gonna skip through this one. One bill that hasn't been mentioned, or maybe it was just mentioned slightly, was the California Omnibus Act, and that was SB 65, Senator Nancy Skinner. And that bill really expanded access to comprehensive maternal and infant care. The key provisions, this provided, required Medi-Cal to provide doula care coverage. That was very critical for Medi-Cal recipients, and it also extended coverage for postpartum care to 12 months, among other areas. I will skip again through AB 2319. And then we're going to move forward to some a bill that we're working on right now, and kind of moving to the whole issue around access to quality care. During the pandemic, one thing that studies found was that there was a really increased desire for out-of-hospital birth. Some of the studies indicated that for Black women, the increase for a need for out-of-hospital care rose by 38%, and for Hispanic, it was, I believe, was 30%. At the same time that there was this desire to look at alternative methods for birth, Cal Matters began to report on labor and delivery boards throughout the state of California that was closing at a very significant rate. And so what happened was you had this increased desire for alternative methods of delivery at the same time that the access to those alternative methods, or just even delivery methods, was decreasing. So in the past decade, more than 50 labor and delivery wards have closed throughout the state of California. And as a result, we have maternity care deserts in the state. And of course, this lack of access to maternity care has disproportionately impacted California's low-income, Black, Latina, Indigenous, and rural counties. Of course, when maternity wards close, particularly in rural counties, birthing people have less prenatal care and the rates of preterm birth increase. Currently, there are 12 counties in the state of California that has no labor and delivery wards in the county at all. Let me go back. Recognizing that there is this lack of access to other care, Assemblymember Bonta introduced AB 55. We are calling it the Freedom to Birth Act. It was introduced on December 2nd, 2024, and I'll talk about what that does. So one thing that we recognized that there is a safe alternative to in-hospital delivery, and that is birthing centers. A birth center is a safe alternative to maternity care for low risk, and I emphasize for low risk birthing people. They specialize in child care and care for low risk patients in an environment that's usually less restrictive and more home-like than a hospital. Unfortunately, current, outdated, and what some say are obstructive licensing requirements are impeding the birth center's ability to obtain licensure. And these are presenting significant barriers to that care. There are a couple of areas when we started talking to birth center owners that were preventing them from being able to get licensed. One was a requirement that they enroll in a program, the Comprehensive Service Perinatal Services Program, which they felt was duplicative of their standard of care that they're already using, and in some instances did not even come up to the standard of their current practice. The second barrier identified was that a birth center is required currently to be within 30 minutes of a hospital that has labor and delivery services. Well, if they're closing throughout the state, that's not going to happen. That's just not going to be possible. And then the third requirement was that these birth centers meet facility requirements that were similar to hospitals. It's the opposite of what they're supposed to be. They are home-like environments. And the picture that I show there at the top is a birth center that was in Sacramento, Midtown area. It's a 100-year-old building, beautiful home-like environment for delivery. But they could not get licensure because the state was requiring that they made $50,000 worth of renovations to this 100-year-old home that had absolutely nothing to do with the safety of the mother or the baby. And so what's happened, of the 27 birth centers that are currently open in California, you don't have to have a license to have a birth center, but only 4 are licensed. Over half, or close to half, as was stated earlier, of California births are paid by Medi-Cal. And so in order to get Medi-Cal reimbursement, a birth center will need to be licensed. And also to get some commercial insurance reimbursement. Freestanding birth centers, there have been many studies that freestanding birth centers have demonstrated excellent outcomes for birthing people and infants. There's reduced preterm and low birth weight rates, decrease cesarean rates, increase breastfeeding, and especially in this budgetary time, for each birth in a birth center, it saves Medi-Cal about $2,000 over the cost of an in-hospital birth. So AB 55 would delete the requirement that an alternative birth center be a CPSP provider. Instead of the 30-minute proximity requirement that's currently in law, the birth center would need to have a written policy for hospital transfer that they work out with the birthing person. And this is done routinely right now in Texas, of all places, also Washington State, and we understand that New York has recently adopted this rather than an arbitrary number that hasn't proven to be safe in their state law. The other issue, I'm going to wrap this up, I got 1 minute note here. The other issue that I had mentioned about the facility standards, that issue is currently being dealt with on a separate track. The Department of HCI is looking at their requirements and promulgating new regulations that we hope will kind of get us over the hurdle for this piece. So currently, AB 55 has made it through the Assembly and through the Senate policy committees. It's in appropriations scheduled to be heard this Friday. I'd ask for you all to send positive thoughts up that we can get it out of appropriations and onto the floor and then to the governor's office. I want to quickly mention just a couple of other bills that are currently pending right now. Senate Bill 32 by Dr. Weber Pierson, who spoke earlier, would require the state to develop and adopt standards for geographic accessibility perinatal units to ensure timely access. That bill is also scheduled to be heard in appropriations on Friday. Another bill that's specific to the rural area is SB 669 by Senator McGuire, and it would require the Department of Public Health to establish a 5-year pilot project to allow critical access. Instead of the traditional labor and delivery units, they could establish standby perinatal units. That bill is currently scheduled to be heard on Friday also. And then finally, AB 1386, that bill would have required that hospitals provide perinatal services, that they include that as their basic service. And unfortunately, that bill was held in the Assembly Appropriations Committee and is now an inactive bill. So our challenges, there's still more work to be done. Racial disparities, even in this progressive state, point to the need for targeted actions, continued enforcement of the implicit bias training, equitable access to prenatal and postnatal services, anti-racist healthcare practices, and very importantly, but often forgotten, is community investment. Thank you.
Good morning.
Morning.
Happy Black Breastfeeding Week.
Thank you.
It's what, is it day 3? Yes, day 3. And thank you, Rhonda, for inviting me. As was shared, I'm Ajwa Jones. I'm actually here not in my current role, but it's hard to leave that role. But as a community representative, found in the early 90s by a nurse while I was working with the Immunization Project as a former teen mom and a student in my last couple years at Cal State Dominguez. A nurse found me and said, hey, I'd love for you to come and work with me at this program that we're bringing to Los Angeles, and that was the Black Infant Health Program. So I was the first community health worker and perinatal health educator for that program in LA County, which really brought me to this work. So today, just in case some of this conversation might be a little triggering, but I'm gonna come to you speaking from the voices of our community, the stories of 2 unforgotten mothers, but it really speaks to the tragedy that is most preventable, but that is impacting our, not just California, but our nation far and wide. I'm going to come to you talking a little bit about April Valentine, who was, and my colleagues have really represented very well, sharing the data. And I will say that even though many of our moms have Medi-Cal, many of them are educated. Far and wide, Black women are the most educated in this nation, but many of them are educated and employed, and many of them have made the choice to give birth, but lack the either jobs that allow or provide appropriate health insurance and do have to apply and receive Medi-Cal. And so what we're facing in this nation can be very critical to us not moving forward, but going backward if those cuts are allowed. But what I will say about April is April was a college graduate from Cal State Northridge. She had purposefully planned this pregnancy and birth with her partner, Nigel Robertson. She actually had a written plan on her board that she detailed out. And if you ever look up, Abby Phillips did a interview on April with Nigel post her death. But she really was excited about Anaya's arrival. What I can say also is she was a hairstylist in her part-time work, but she also worked with foster youth who she built a very strong relationship with and was doing a great job in her community. And April died in January of 2023. These are photos of April, and then these are pictures of Nija and Anaya post April's death. April was at Sentinel Hospital. I should also say that she went and saw a specific provider. She had shared with that provider that she wanted a doula. She actually had her doula to meet with the provider, and the provider had agreed that her doula could be present during her birth. Nigel actually was not a resident of California, but had met April like the second day he arrived in California, and they built an immediate relationship, and he stayed while working in his job in Los Angeles to, experience pregnancy and birthing with April. And he was the only one that actually saved really Anaya post-delivery. And so I'll tell you a little bit more about that as we go along. This is Mrs. Bridget Cromer. Bridget was a wife and mother of 5. She was in her nursing career and had plans and had already scheduled her CLEX nursing test that she was going to take. Divinity was her and Freddie's last planned child. She had requested a tubal ligation. Actually, she really wanted more children, but they had decided to stop at 5. She died actually the same day. So this picture here prior, as you can see, this is her going for a planned C-section. And just within hours of that C-section, hours after delivery, even though they had a struggle the entire time there, they weren't prepared for her. Even though it was scheduled, they said, oh, we're understaffed. We really weren't planned for you to come here today. They went ahead with the process. And as her husband went home to take care of the children, she was awake, had yet to see her baby, died while he was home resting, and he received calls that he had missed through the night. In this story, this bit of testimony is I've been working with. Once I met Nija, I also was able to meet and build a relationship with Stannis Askew, who was April's doula, who she got through Frontline Doulas and a scholarship. And again, like I shared, Stannis had met with the provider, and so like she states in his, she was not surprised when she was initially denied access to April when they went to the hospital that busy January night. Actually, April had been sent by her provider to the hospital. Through the night, they had asked for the provider. She had said she would show up. She did not show up. She also asked to see other physicians because she complained of issues with her legs. They would not allow her to see another provider. They expressed that your physician does not like other providers to see her patients. They also complained and asked her food. They said, we really don't have anything. Nigel walked in the pouring rain to get April food. He came back through the night and experienced while him and her sister were there, April complained throughout the night of having leg pains. She asked for further assistance, asked for a doula to come. The doula was denied access. And part of that is they had built a relationship with the provider. When the provider arrived the next day in the afternoon, they had went that evening. The night before, when they arrived, she said, "Oh, I was busy working on my boat, but I'm glad that you're here." And she said, "Well, I really wanted to have my doula here." And she was like, "What do you need your doula for? You want some oils? I can go to get that out my car. What's your doula gonna do? You got your boyfriend here, you got your sister here. I can, me and my folks will have this done within a few hours and he can go on to work." Well, within a few hours, April was deceased. She had actually coded. The nurses stood around. They did not come to help initially. Nigel had to kind of act a little bit, wild to get them to help. He was the one that provided CPR. They actually delivered Anaya in the hallway. While the doctor ended up screaming out for them to bring her the equipment and tools, because by then April was already deceased and they had to immediately remove Anaya. Through this time, we've all had to practice managing our emotions and how we really have gotten through that. Stannis made a promise to April and the family. She honors her annually by walking. She honors her memory by keeping her spirit alive, participating in the half marathons, and working with other women to ensure that they're able to be fully supported. During this journey, I also became more of a doula to those dads, to both Freddie and Nigel, bringing them together. You can see them here in this picture with our fatherhood engagement coordinator, Davion. You can also see in the first picture, Freddie with 3 of his children. And the beauty of these gentlemen is they both have stood up and advocated. The sad part about it is April's story was more widely talked about instead of Freddie's, and I attest that to our community that did not support a father of 5, maybe because he lived in the projects, maybe because people thought that it was not as important for him. But he was the one who went and advocated to the medical the coroner to make sure they appropriately marked down his wife's death, the cause of death. He also investigated that provider and found out that provider had a number of other issues that had not been addressed, and that provider is still allowed to, both of the providers are still allowed to care for women even though they have these additional issues or preventative care that they could have provided but they didn't. And we also lack that in the work that we're doing. I will say of both of the individuals and the dads, we were able to, as a community, come together and wrap our arms around them and really support them during that journey. Naya was not even given Nigel the respect. They put her sister on the birth certificate, even though while there, they both filled out the documents. And that caused him to have to stay longer in our state to make sure that he was able to be put on that birth certificate. There are many times where we had to navigate with him, his mental health support, providing support while engaging with the attorneys and meeting with other staff, and not having family here to ensure that him and his child really were supported and thrived throughout this journey. I actually went to visit them in Louisiana. Well, he lives in Mississippi, but I was in Louisiana, so I drove over to visit. Anaya is now 2 years old, thriving and surviving and doing great with family there. For Freddie, it's been a longer journey, him being able to try to stay employed and raise 5 children, but never being acknowledged by the hospital, never being acknowledged even by our coroner's office to appropriately address how his wife died. So the importance of bills like SB 464, which I also came to lobby visits for, the importance of bills like SB 65, the Guaranteed Income Pilot, and also Medi-Cal doula expansion really allows for us to really engage and uplift and support pregnant and parenting women and their families. And part of our work in LA and what I'm excited about is if we had not been doing what we were doing, I was able to, in 2018, come up with the idea based upon my work with Whole Person Care to establish a community action team to bring community and government together in a 50-50 partnership to address the high rates, the unacceptable high rates of infant and maternal mortality. There was no funding. There was no data search or anything being done. What I realized that I've been doing this work for over 30 years and I hadn't seen a halfway reduction of the infant mortality rate in my county. And I felt as a public health leader, we weren't doing an excellent job. And so I was able to bring together over 100 folks. I went out in community and said, hey, we're going to establish this. Are you interested? And we started in South LA. We established now, we have 4 community action teams around LA County. And we've been funded by the state through our PEI program. We've also had other philanthropy type funding to be able to keep these community action teams in place where folks with lived experience are able to be participants in establishing work, not just work, but celebratory practices around supporting pregnant parenting, women and birthing persons. We offer free doula services. We offer fatherhood engagement. We support and have expanded the Black birth worker pipeline. We support midwifery care. And we're doing all that we can to ensure that pregnancy is uplifted. Pregnancy is a place that, where folks can really enjoy the journey, and that it should not be a place where it is preventable, but we just allow systems to continually to be negligent towards Black women, Black families, Black people. And that's what we're doing. And I'm truly excited about it. And I'm still continuing that journey we are with the dads and with our overall community. And so not much more needs to be said than that. I think in this point, thank you.
Wow. So where should we start? So I'll ask a few questions of the panelists, and then the audience will have the opportunity to ask questions. So there are 2 mics in the room in both aisles. So if you have a question that you want to ask, please, I invite you to come up to the mic to do so. But I think where I want to start is something that Dr. Malawa said. When you were talking about training, you talked about it's kind of like train and hope that things change. And we know that, training around implicit bias is not the silver bullet that's going to change things or make a difference. But what do you think can be done to not only change behavior, but to really kind of eliminate what's happening and some of the root causes of the disparities that we see within Black women?
Okay, those feel like 2 very different questions to me, but I'll start with what I think can be done in terms of training. I think one of the things, I love to do actual trainings of providers and other people in the system, but one of the things that I've noticed is that we train people, they gain this new information, but they don't necessarily know how to translate that new information into new behaviors. And if we don't make it really explicit, then nothing can change. And I think we in this country get really stuck in our thinking about racism. And so whereas, we might be able to say, like, look, this is where the lead is, harming children, and then people can, figure out what needs to happen based on that information. We don't do that well in this country. And so what I have had a lot of success with is actually creating tools that really structure the behavior change that we want to see. And so whether that is like, this is the list of questions that I need you, home visiting nurse, to be asking a racially discordant client to make sure that you're not accidentally engaging in anti-Blackness, or this is like a certain checklist that you can look at. I've used like non-violent communication skills with primary care providers to help them navigate cross-racial differences. But I think the point is that we can't just kind of say, hey, implicit bias exists, power dynamics exist. We have to say, and your job as a nurse, doctor, is to do X, Y, and Z, and this is what you need to look out for. So I think we need to really structure the behavior change, and then we have to measure it. I think that it's really unlikely that people who are super busy in their jobs are going to just automatically make these changes. And so we have to measure it and create accountability. And I don't think that that means like you, individual provider, are the problem. But I do think that we can look at, racism among providers as like an institutional issue, What about this institution tolerates this behavior? What about this institution makes this feel like this is a viable way to go forward, et cetera? And so in the same way how like you can't talk crazy to customers at Nordstrom's because that's against the Nordstrom brand, like what about these hospitals allow people to talk crazy to patients, and why can't we have more like Nordstrom's hospitals? So that's kind of my thinking about that. But I think, the truth is that clinical medicine can only take us so far, because the problem isn't a lack of clinical medicine. If it was, I think things would be much easier. But the reality is that Black birthing parents are under a lot of stress because of structural and institutional racism. And so if we want to see real viable change, we have to do a few things. One thing is I think we have to take like a corrective approach. Racism has been a 400-year-long program in this country where we have systematically extracted resources from Black, Indigenous, and other communities of color. And so it's ridiculous to think that these communities are going to be able to like bootstrap themselves back into health. We have to actually put back what has been taken out in some kind of corrective action form. And so I think at a minimum, like that's one of the things we can think about. And then we need to look at why is it so stressful to be Black or Native or Pacific Islander giving birth in this country, and how do we actually make it less stressful? And these are the same things that give us, educational outcome disparities, mass incarceration outcome disparities. So if we're addressing racism as a root cause of birth disparities, we are simultaneously addressing racism as a root cause of cardiovascular disparities, educational outcome disparities, et cetera. And so it's hard, I think, especially in this current political environment, to start to think about what does it mean to address racism as a root cause. But I do think that at a starting place, we can think about what it would look like to take some kind of reparative stance.
Great, thank you. I want to clap for that. So, Dr. Chambers, I know you also talked about your program and the work that you're doing, but from an accountability standpoint, do you have any insight as to how, in addition to the training, in addition to the measurement and metrics, what we can do around accountability?
So I agree with Dr. Malawa. I mentioned like it was a 6-year process, and if any of y'all are thinking like, why did it take you 6 years? Because I've talked with people, and what providers did say is that they mentioned that if we want to see a difference, that it is a system, right? They said that they were taught to racialize people. They were taught to discriminate against people. They were taught that Black people have high pain tolerances, and that there is no accountability at the system level. And so in the qualitative study that I did, they were really saying, I do not want to take another training. I take several of them. I need you to teach me actual skills, how to actually be a better provider. And then once that happens, what is going to happen with the system so that I can be allowed to do these things? For example, if I need to spend an additional 15 minutes with my Black identifying patients, my system currently does not allow me to do so, right? If I need to document more things, right, so that we can track accountability, such as, making sure that, certain issues were discussed, right? Just like exposure to racism could, result in X, Y, and Z. There is not additional time for me to do that, or there's no place for me to actually track this. One thing that also came up as well is providers, unless you tell them data for their actual facilities, they do not believe that they're part of the problem. And so the reason why it actually took a long time is because I had to get data for the hospitals I was partnering with so they can know, hey, the patients that you are seeing are contributing to this number. But what was also so alarming is that they didn't know the data for their facilities. And so I feel like that is one step that we can do towards all of this, is like, how can you report, your data around, maternal equity and infant health equity to your staff on a quarterly basis. So you can know, like, that is one measure to know, how am I doing, right? I'm a part of this group. How are we taking care of everyone? Whereas, when I was doing the interview process, it was actually maternal death at the hospital that I was interviewing in. And you can see the shift in everything that happened. So when the event happens, everyone feels, remorse, but actually the hospital has policies in place to protect that provider, to protect that facility. And so I think also having some policies in place to protect Black women and birthing people and their families could also be a way to kind of help with that. We do have the Earth app, which is really, really great as a way for people to know where to birth and where not to birth. And we do have hospitals who are partnering with the Earth app to actually do that. So they're having some type of patient experience data to inform what they're doing. And so I would just say, like, I think this is all great steps in the right direction, but that there'll need to be, I think, as Dr. I'm speaking into existence, Ajwa. I was about to call it Dr. Jones. As Jones mentioned, it needs to be partnerships, right? We have to have interdisciplinary teams in order to see change in these spaces, because if someone like me, I want to create a community-centered training, but I need access to the healthcare system, and really it's hard to do that. And so I would just suggest that as we continue to have these conversations, that we need to actually involve the healthcare institutions to kind of see what we can actually implement in those systems and what data we can extract and how we can actually change things.
Great. Oh, yeah.
I just thank you for that, Dr. Chambers. Yeah, I'm in a fellowship, so all right. What I'd like to say is, too, with April's case, what Centinela Hospital did, they were fined, I believe, about $75,000, but they were still able to benefit. I think there was like maybe around 60-something thousand they still received. But then they also closed the hospital, the maternity ward. Well, they closed it in the city of Inglewood. Now, if you know anything about what's happening in the city of Inglewood, we have about 3 different entertainment centers in one area. We have a number of residents in that area that are without a maternity ward. I actually had a client go over there who suffered from maternal mental health issues, as well as seizures during her pregnancy, who her claim is that she could hear things that they were saying to her. They had her heavily sedated, but she's like, I actually coded a couple times and they did not do a great job with me. And that was her just being there for an emergent issue. The hospital closures are not helping and don't benefit. We need to look at midwifery care, where we're not seeing these numbers and these issues, but we're not getting the education support for midwives to continue their work. We're not being supported to actually really, like Sandra was sharing, those birthing centers, if they're having great success, it's costing us less. You don't have to have babies in the NICU. You don't have to pay post of someone's death that could have been preventable, and so much more, and then just be very dismissive. Those are the challenges that we face. With April's mother became much more sicker after that, because not only did she lose April, they had just lost April's dad the year before. And so these are like critical points in our community that just even the amount that's per, I think the medical malpractice amount is very disrespectful to a person's life and livelihood.
Thank you very much.
Thank you.
You're welcome. Yes, so I just wanted to ask if you could talk a little bit more about the Earth app, just people in the audience who may be interested in knowing more about it.
Yeah, I feel like Dr. Malawa may have more information than me, but it is an app where Black women and birthing people can actually rate their providers, and so it is like a community of Black people who are about to birth, and you can go there and get some insider knowledge, right, to say, okay, am I going to experience some discriminatory care with this particular provider? Where should I go? Where can I get resources? And I believe for California, didn't they start in San Francisco? Was it first? Or was it in?
No, it's LA.
LA? Okay.
Well, New York.
Yeah, but when
but
you
for
came to
California,
but then
okay.
they brought
LA and here.
to LA. Kimberly
LA,
said-
and then I know they're now in SAC as well, partnering with Sacramento. And so it is an amazing resource, right? And so, yeah, I'd allow
But it's Earth like birth without the B. It's not like the planet Earth. So IRTH is how you find it.
Right.
And it's
like
not
a
just for
Yelp
Black
type
folks.
of-
It's for anybody experiences marginalization, for queer birthing people, for Latina birthing people, for disabled birthing people can also put reviews, like a Yelp for birthing people.
Great, thank you. And so, Sandra, I want to make sure I say that correctly. Yeah. So I think a lot of the things that Dr. Chambers mentioned seem like to me there might be some policy opportunities or initiatives that may be able to address some of those. I would like for you to, if you can have some perspective on that.
Okay, so we're talking about accountability or some of the structural.
Yeah.
I think we had perfect examples talked about this morning in the passage of Senate Bill 464 that required the implicit bias training, something that was critical and something that was very much needed, and it went into law effective January 1st, 2020. But it wasn't until a year and a half later when the Attorney General did a compliance review to see if hospitals were complying with the law and found out that only 17% of the hospitals had actually implemented the law. Thus, AB 2319 that put some teeth into the original legislation. So to me, it's critical when these laws are passed. We can't assume that people are going to do the right things and implement them. And some of that falls on the departments that are required to implement, but then also those that the requirements are meant for. What I would like to see in a perfect world would be one, whenever there is legislation passed, that automatically that compliance piece is embedded in the legislation. But beyond that, I think that whoever's required to implement these really need to be accountable to the legislature. And I know in years past there were legislative reports that were done back to the legislature to say, we implemented that. But true confession, I was a former state bureaucrat, and I know where those reports went. And so I think that transparency and bringing light to day around a lot of these policies, I would love to see reports that go back to the legislature and that the legislature has some way to publicly, some centralized area that the general public could go in and say, this is what happened. They're complying, they're not complying. I think that's the only way that you're really going to be able to hold folks accountable. The legislature does a lot of work, a lot of good work, but unless, they say the devil's in the detail, unless it's actually implemented and rolled out to folks, it's kind of for naught.
Thank you. And then, Paula, I'm curious about how the One Big Beautiful Bill might impact CalAIM and some of the great work that DHCS has been doing. So can you talk a little bit about that?
I'm not going to call it beautiful by any stretch of the imagination. So I think, there's a lot that's been published on this in the literature and the news. There is no way to extract $28 billion out of Medi-Cal and create 3 million new uninsured people in California and not have it cost lives. And so that is going to happen. People are going to die. There's lots of estimates you can find online because of that. I think as we specifically think in that dire state, what can we do to minimize harm, right? Like, what is our harm reduction approach? One, on the maternity side, many of the people that may lose coverage because of immigration status or work requirements, most of them will still probably qualify for pregnancy-related coverage, and our state did do the 12-month expansion. So that is a good thing, at least during pregnancy and 12 months postpartum. Does not help with any of their medical or behavioral health needs prior to pregnancy or after that 12 months postpartum, which are equally crucial. I think the other thing to recognize is that people don't stop getting sick just because you take away their insurance coverage. And so who's going to bear the cost of that? It really is, as our uninsured numbers rise, our providers, our hospitals are going to be stressed. And we all remember those times before the Affordable Care Act. And so I think in the midst of that, two things. One, there's going to be a lot of stress and chaos, and our healthcare delivery system is going to be struggling as these changes go into effect. And I think in those times, it's easy to say we're overwhelmed. We can't focus on Black birthing mothers and families, and that's the wrong answer. And so we need to stay laser focused that, things are going to get tough, and this is the work we have to do, right? And the core tools in our toolbox, they're there. Like, we can redesign systems. The Medi-Cal coverage for pregnant and postpartum people and reimbursement, it's not going away, right? None of the current budget proposals contemplate stripping away midwifery care or doula care or enhanced care management or a lot of the progress we've made in CalAIM. And then I think the second piece is we are going to have difficult budget times, and how do we think about making our dollars go further and getting more value for our care? And so I think some of the great examples that folks have talked about, where can you invest upstream so that you get better health outcomes, right? Because we would rather prevent all of the low birth weight rather than have those babies end up in the NICU. How do we reduce barriers for birthing centers and midwifery-led care and greater access to doulas, all of which have been shown to reduce costs and improve outcomes? And in our birthing care pathway, like, that's a big part of our strategy. Our members told us we want access to that care, and right now, because of a lot of the factors you heard about, it is hard for our members in every county to have access to the type of care that they want that is also good for their health and good for the state.
So I've asked quite a few questions now. I would love to hear from the audience if you have any questions that you would like to ask any of the panelists. So, oh, I thought we had one taker, but not, nope. And please state your name.
Can you hear me?
Yeah.
Okay. My name is Mashariki Kidumu. I'm from Los Angeles. I am a public health strategist and a birth equity and justice advocate. Also director of statewide California Black Birth Equity Summit that many of you will be participating in, and thankful for that. I guess my question is, as we see this sort of like blatant anti-Black racism that's happening from the top down in our government, and attacks on equity programs and programs that we know that'll improve outcomes from our Black families, what can we do as individuals, whether it's in our private lives, whether it's within our institutions, to, I guess, push for change? I know it's not all on us, but I'm wondering, sometimes I feel like really helpless, you know, in the current times that we're in. And so just wanted to know if, like, our panelists, if they have like calls for actions for us to do in our personal lives, whether it's in our communities, where there's things that we can do in our workplace. Thank you.
Who would like to take that question first?
Hi, Mashariki. So I didn't mention this before, but the Abundant Birth Project actually got sued a few years ago by some jerks in Texas who said that our work was anti-constitutional. We were getting state funding by that point, and so the state actually decided to defend that lawsuit, and we're still, I guess, in it. But we completed enrollment a couple of months ago, so bwahaha on them. But here's my point. We also lost $2 million of NIH grants recently, and so the Abundant Birth Project has kind of been living in the environment that everyone's living in. We've been living there for the last 2 years. So the first thing I want to point out is that we've been living here for like over 2 years, but we're still here and we're still doing it, right? And so I just want to remind you that just because, you know, the federal government is saying this one thing, it doesn't mean that we have to do it. It doesn't, right? And I really respect the state of California for allowing us to identify, you know, eligibility criteria for the Abundant Birth Project so that we could continue to acknowledge that Black folks are disproportionately impacted by birth injustice, but also we can find things that are going to be viable with the law in terms of using this approach. And so that's one of the first things I would offer to everybody, is to not back off of the work, but figure out creative ways to keep on doing the work. And so there are resources out there, but one of the first things is really just thinking about, are there some racial and non-racial criteria that I can match up to make sure that I'm still reaching the populations that are most disproportionately impacted? Relatedly, I would offer to everybody that we all need to continue to take what I'm going to call calculated risks in the work that we do to continue to advance racial justice. And so what that might look like is, maybe I'm not like all full-throated on my website about like this and that, but I'm still going to do the work and make sure that community knows what time it is. But another thing that I've learned recently, because I'm like basically like a constitutional legal scholar at this point, and so one of the things that I've learned is that only Black people or only people have a race. And so that means it's okay to talk about Black community. It's okay to talk about Black birth. It's okay to say, like, I explicitly want to see improved Black birth outcomes. You can say that on your website. None of that is illegal. Like, where you get into trouble if you say, I only want to help this Black person. And so only individuals can have a race under the eyes of the law. Issues can't have races. Communities can't have a race. And so it is okay to continue to focus on Black birth justice in a calculatedly risky way. And then the last thing I just want to mention is that, like, it can feel like really dark times right now, but one of the things that I remind myself and the rest of my team is, like, think about how dark it must have felt, like, the day after Martin Luther King got assassinated. Think about how crazy it must have felt for Black folks in this country in, like, 1861. You know, like, things must have felt so hopeless. It was probably impossible to even imagine a better future, and yet our communities persisted and we found our way to something bigger and better. This moment is temporary. It might last a minute, but it is a temporary moment. And there's something inside of us that is so strong that we can definitely prevail over this moment because folks are already doing it. And so what I say is, don't back off the work in your individual lives or your professional lives. Just get creative about how you do the work. Continue to find opportunities to say that this is important, and then continue to remind yourself that your ancestors gave you everything you need to survive this moment and then some, right? So that's what I say.
We're going to go to this side of the room.
I want to add something to that, too. So I say Dr. Malawa is goals for me. I feel like she is an expert funder. So I would say on my end, I have experienced not only ABP funds being taken away, but other funds, and actually my work, you know, disappearing. Like, people asking to, you know, if you want to apply for certain things, you have to talk about it in different ways. And I would say one thing that has been reassuring, and what I think we could do, is collaborate with one another. Because, you know, I feel like sometimes we're in the situation where, like, okay, well, we are now all, the system, right, is making us feel like we have to compete, you know, for funding, but we don't. We can continue to work together and go after funding together. And so I feel like that has been a thing that we haven't yet talked about as a larger community, but that's something that I want to put out in the space for us to continue to do the work, because the money is decreasing, but we can decide as a collective where we feel like the best impact would be for this particular time, and come together and work towards that. And then another thing I would say is we need to schedule rest. I'm working on that. You need to schedule some rest, because we are going to be working extra hard right now, but we know what's up, right? We know the system. We know that this is structural racism playing out. I wouldn't have thought that we would be doing this in my lifetime, but we're here. And so take time to rest, because the work is going to get challenging, and it is hard.
I would just, last thing, would say that, and thank you, Dr. Chambers and Dr. Malawa, that do not let up off of your policymakers. Still meet with them, still have conversations with them, with lunch with them, with their staff. Talk about what is at stake here. If Roe v. Wade was overturned, if birth control is on the books of, you know, removing, you know, those options, then we have to understand more people are going to get pregnant. And so they are going to need to be supported. And if Black folks, the health of Black folks improve, for us, it improves for everyone else. Dr. Weber Pierson shared that earlier. SB 65, SB 464. I was a part of the team in developing that with Black Women for Wellness. Kimberly is here, that also is responsible for the state, the Centering Black Mothers report. Kimberly, raise your hand so folks can get the QR code and card from you. It's imperative that you understand that if we don't keep our foot on the gas, we are going to go back, and folks will die, and they will die unnecessarily. We lose over 4,000 Black babies in this nation before their first birth. That is clearly preventable. It's not necessary. They had a CNN report that said Black babies fare worse in the care of white doctors than they do in the care of Black doctors. But there was no difference for white babies in the care of Black doctors. Actually, they did not fare worse. This means we as a people are failing individually. And I just want to, we could talk about the Hippocratic Oath at some point. It had nothing to do with race. So hold people accountable and stay connected in the work and don't give up.
Next question over here.
Okay. Hi, my name is Siobhan Washington. I am the program supervisor for the Black Infant Health Program in San Mateo County. Yes, we still have a Black Infant Health Program in San Mateo County. We're just fortunately able to be funded by our county. So, Dr. Malawa, you answered one of my questions. I wanted to know more about the lawsuit because we're doing something similar in San Mateo County. So I just wanted to, just kind of get some information about that, but you gave it to us. So I have two questions. Are there any efforts around training more Black women to be midwives? Any efforts around midwifery training here in California? And the other question is, so the bias training that providers are supposed to undergo, is there a specific curriculum that is being used, or is it just them like contracting with an organization and them coming out to provide it? So those are my two questions.
So I'll start and anybody want to jump in. Your first one in regards to, say that last part again.
The first one?
Training. Common Sense Midwifery School is coming to California. That
Okay.
is the Jenny Joseph way. And so they are looking to implement that. They do need funding. There's also midwives that are not very aware of the policy. They had a meeting a couple weeks ago in LA, and I mentioned AB 55, and not many folks were aware. So talking about bringing the midwives together to have a policy work group so that they can be aware and know who they should be talking to in their community that should be voting on these bills and stuff. If you all know, the federal omnibus has yet to pass. It had like 13 different bills. It wasn't based upon race. It's based upon women, children, and birthing, and fathers as well. So fatherhood engagement is critical. Your other question, I lost that for a minute.
The other question, I wanted to follow up on the last question. Will Medi-Cal cover midwifery services if you requested?
I can explain that one.
Yeah, it's the challenge of that is the midwives are not appropriately compensated. And the amount of work that they would have to put in, it just becomes challenging for them with that. But then there's some of them that are offering free services, and then they still will work with you up until the point, and folks can still deliver in a hospital, but they are providing great care.
Yeah.
Do you want to talk about the midwifery training?
Yeah.
Yeah, just on both of those fronts. So first thing, I think we fully recognize that the midwifery workforce is not diverse enough to meet the needs of our communities, right? So I think there's sort of a pipeline and workforce training issue. Then within the Medi-Cal space, we know that not all the midwives in California, independent of their race, et cetera, actually participate in the Medi-Cal program for some of the structural barriers. And so two pieces on that. You all may be tracking that DHCS and California were accepted into the federal Center for Medicare and Medicaid Innovation, Transforming Maternal Health 10-year demonstration. So as a part of that, we are actively going to revise how we pay for maternity services. So figuring out the reimbursement specifically for midwives is part of that project. We're really excited to dig into that to address the structural barriers. In the short term, while there is, if you're in fee-for-service, the rates are sort of set in a specific way. Our managed care plans actually have a lot of flexibility to negotiate rates with providers, including midwives, that go above and beyond sort of the fee-for-service rate. People don't always know that. And we, as a part of Birth and Care Pathway, are updating how we look at access to midwifery care. So in current state, every managed care plan has to include midwives, but I think our existing policy says you have to have a midwife in your contract, right? So if you're in LA County and there's one midwife in your contract, that's not going to meet the need. So we're revising that to really say, how do we get access so that every member who wants to have midwifery-led care can actually receive that care?
Okay.
And I just really want to add briefly that recently, San Francisco, UCSF used to be one of the main places where people got trained to be midwives across the entire country. But recently, UCSF made the decision to change its midwifery program into a doctorate program, which means that it has way higher requirements, it's harder to get into, it's harder to complete. And so we actually lost a critical training resource when they made that transition. And I read something recently that I want to say, a city college in Southern California is actually looking to start to have training courses at their city college, and I personally have been harassing San Francisco City College to do something, and so that is something we desperately need in California, is more opportunities for midwives to train.
Okay.
And then I
Thank
feel
you.
the last question, so around, yeah, I do remember it. So SB 464, not SB 2319.
Yeah.
There are some recommended trainings that providers can and healthcare institutions can take, but you can really take whatever you want. And if you look at the report that kind of came out, some people are doing seminars, some people are doing online. They're very different formats, which is what I try to briefly highlight a little bit, is like, you know, there's now this mandate, but there really is no like measurement of the effectiveness of any of the trainings that are currently being provided, to kind of say, we want providers to take this training, but is it actually doing what we intend for it to do?
Did you get all of your questions answered over here?
Yeah.
Okay,
part.
great, thank
Thank
you. And a
I'll
question over here.
Thank you. My name is Shanae Bowie-Hussey. I'm the founder and CEO for Leaf for Joy Foundation. My question is kind of like a 30,000-foot question. If you were able to create the perfect system in California for healthy birth, what components would that consist of? Just because the panel is so diverse, I just would like to hear what you would say individually to the perfect system in California for birth equity.
So, Dr. Malawa, would you like to start?
I mean, definitely I would want everybody to have the financial resources that they need for healthy births and pregnancies as a starting place. And then, just because I get so irritated with my colleagues, I would love there to be actual financial consequences to being a racist doctor. I would love that. So those are some of the things. I think also, personally, like I was mentioning before, I think that, I know we've talked about it in California, but I think we need a reparations plan, not just for Black folks, but also for Native folks and Pacific Islander folks if we want to see birth equity in this country.
Anyone else want to comment?
I think everybody should comment the thing. At least one thing. Add it to our new omnibus. Let's go.
Andrew, you want to go first?
Yes, you know, one thing that that's really a concern for me is that we create policies in our ivory towers and don't really listen to the communities or those that are directly impacted. What I would like to see is that we really listen, and I think Western Center modeled this when we were starting to look at birth centers. We conducted under UCSF a series of listening sessions throughout the state. We had in-person sessions in Los Angeles and Oakland. We had virtual sessions, some that were targeted toward midwives, but also for individuals who had actually given birth in a birth center to hear you know, what their experiences were, and actually came out with a report that had some recommendations from each one of those groups. But what I see is sometimes when legislation is passed, they'll say consult stakeholders. So we'll reach out to folks and ask them to come and participate in an advisory group. Often they're running nonprofit organizations by just threads, and we don't compensate them for their time and their value and their expertise. And so for me, in a perfect world, I think we really need to do a lot more to really engage the community and those that are impacted to pay them. Western Center, we provided stipends to those that participated in our work groups. And I just think that this is something that we can't forget those that are actually impacted and really listen to them.
Thank you. For me, this shirt is cognizant of what I believe, We should create and establish maternity care and perinatal health where we're supportive, where we're protective, and we're relieving those women and birthing folks that are giving birth. It should involve midwifery care along with physicians. It should involve fatherhood engagement. It should involve lactation education, awareness, and support. It should also involve perinatal education throughout the person's pregnancy and postpartum and mental health support to address perinatal mood and anxiety disorders and make folks aware, including the entire family, because we have been very dismissive after a person gives birth, like, oh, everything will be okay, and not recognizing that they actually could be suffering from some perinatal mood and anxiety disorders and really need medical attention as well as medication. Postpartum support also includes well baby visits and care. I think it is also imperative to have medical plans involved in the work. I was a part of the team that established the first doula board motion that we presented to LA County Board of Supervisors, which they adapted in January of 2020, which really helped to on the expansion of Medi-Cal services through SB 65. I think it's also imperative that, like what was shared, that providers that make mistakes, and maybe they're mistakes, some people it could be intentional. I hear very serious horror stories in nursing with NICU babies and such, held accountable at some point and maybe even fired. Maybe this is no longer the job for you. Maybe you applied and you did the work and you thought you could, and it's not really the job for you. That is really important because we cannot afford to just allow folks to just continue to get away with what we could deem as murder. And so I think that's really the imperative around it, and that we really wrap our arms around those that are pregnant and birthing. Do like other countries, they give people a long time off and guaranteed income. And it's still, they find success. And they're still winning, even though those people took maybe a year or two off. That was given to them. So follow the lead of those that have the lowest rate of maternal mortality and morbidity, as well as the lowest rate of infant mortality and morbidity. Thank you.
Who down the end of the table wants to go next?
The one thing I would add, with my community health hat, would be to invest in preconception care. And I'm going to say ABP has something figured out. I love the abundance coaches. I wish everyone could have an abundance coach before they actually, enter pregnancy. And so investing in that care, knowing that Black women and birthing people are exposed to racism when they're like just chilling in their mom's, ovaries. And so I think that would be something that I would add.
I think what we heard consistently from our Medi-Cal members is exactly that, right? People want reliable, respectful care where the system works for them and where they're not working for the system. And I think all the things you heard about are pieces to get there, but it's also like, how do we force our programs that are largely siloed and all running on their little requirements and tracks and scattered throughout our county and state to do the hard work of integrating and wrapping around that person and providing care, whether that's in their home or in a birthing center or wherever, so you truly can have all the services you need in one place. And currently, everything we do is so fragmented.
Thank you.
Great. Thank you very much. Did someone else? We're good? Okay. Question over here.
Hi, everyone. My name is Keys. I'm a registered nurse and community doula here in Sacramento. And my question is kind of surrounding that Medi-Cal doula benefit. It's great to have, and we love that our clients have access to it. But my question is kind of what is the overall or long-term goals for Medi-Cal and the managed care programs to ensure that not only do we have a doula workforce, but that our doulas are getting paid and understand how to get paid. for a lot of us, like navigating the PAVE portal was kind of difficult. Understanding billing codes and when to send and how to bill is kind of new to all of us. So, you know, we love showing up to the births and being there, but we want to make sure that we're also fairly compensated. And then just the second part, if you guys can speak to, I think it's Senate Bill 626, and I think that's addressing specifically maternal mental health, and what kind of roles do you see doulas playing when it comes to addressing maternal mental health?
I'll start with the first, and I'll let someone else do the maternal mental health if you want to. In LA County, we have the Medi-Cal Doula Hub. And so the Medi-Cal Doula Hub is built to help support those that are doulas and those that want to be future doulas with the key areas are workforce development, technical assistance, evaluation, training system integration, public awareness, and they're working with a lot of the Medi-Cal, the MCPs to make sure that the doulas are getting paid. There are routine meetings. Thankfully, Frontline Doulas is in contract with our Department of Public Health through Frontline and Diversity Uplifts to provide the services. They have routine meetings and check-ins with the doulas, and it has been a significant improvement on the doulas getting paid, also what I believe is the care to our clients in community. I actually put the flyer up front. If you want more information, let me know, but you can stay connected with them at ladoulahub.com, or Frontline Doulas is always posting on their Instagram and social media pages.
Can I just add to that? Is one thing that we've heard from doulas at Western Center is issues around contracting with managed care providers. And we've heard examples of one doula was given a contract that was 932 pages, I believe. And it was something that wasn't even applicable to the work that they were doing. And they were just told, well, just scratch it out if it doesn't apply and sign it. So what we've been doing is Western Center has reached out to a firm that has agreed to provide some pro bono work on our behalf to kind of look at contracts, to answer questions, but hopefully these contracts can be standardized so that the doulas can get paid.
Yeah, I'll just add that, one, we've definitely heard that feedback and are looking at what support can the department provide to potentially provide boilerplate contracts or standardization. And I think we're hearing similar concerns from like CHWs and other peer specialists and other sort of new workforce types who've entered Medi-Cal, and then agree, I think, right, like healthcare billing and coding and reimbursement is as clear as mud, like for everyone, and is really challenging, and it's really hard to do alone. And so in a lot of our CalAIM initiatives, really leveraging hubs where there can be an entity that just makes it easier, sets up the process for everyone, is really where we've seen a lot of success, and we're looking at ways to support scaling those types of hubs statewide.
Sorry, can I add one more thing? Okay, so I love accountability. Well, I love accountability for other people. And so one of the things that Expecting Justice is working on is a Medi-Cal managed care plan report card for perinatal health, because there's so many things that we're asking the managed care plans to do, but there's no accountability for them to actually do it. Mm-hmm. So like, have they contracted with doulas that represent marginalized communities? Do they offer lactation support? Do they have that one midwife, at-home birth midwife on contract? Do they do these basic things? Can you get a blood pressure cuff out of your managed care plan? Mm-hmm. These things that they're supposed to do, but they don't necessarily do. And so we're trying to get that report card out sometime early next year, so that way everybody can kind of put the different managed care plans on blast about who is doing what they need to do.
We're also doing Project 8000, which is focusing on the number of births that we have annually in LA County, Black women birthing, and so working with the managed care programs to establish how they can support us. And if you could just, came from Dr. Franklin, can you just focus and support these 8,000? It will help to improve all throughout LA County. On SB 626, which is Senator Lola Smallwood Cuevas' bill, I will say this, is to really find out more about who's providing maternal mental health in your community. That is a very important bill. I recognize there was a young lady when the eclipse occurred. She actually ended up killing her partner, killing herself and one of her babies. And a lot of people blamed it on, I think she was involved in some other type of, I forget what it is, spiritualism. But at any rate, we recognize that she had had a previous postpartum depression, and then she actually had a baby under 1. And so making sure we lift up the case, working with the postpartum, I think it's called PSI, I have to think of the name of that group, really working with them. We have the LA County Mother Board, where we have mothers who have had various issues around their postpartum depression that came up here to speak, but really delving into it because that's a very important bill. And I could share with you others that could talk to you about it.
Okay, so I'm going to take one more question and then we'll wrap up.
I was actually, I didn't have a question.
Oh.
I was coming up to uplift 626. So if you'd
Okay.
like, I can share what the bill is.
If you want to elaborate a little bit more, we have to be out of the room by a certain time. But
Okay.
go ahead very quickly.
2 minutes. Well,
Okay.
and since you brought it up, did you have a question? Because I can talk to her afterwards, because I hear you're needing the mic.
I know she
Okay,
was standing
she's
over
needing
there.
the
Yeah,
mic,
so
so
tell her.
I'll talk with her, and I can share 626, because Black Women for Wellness is actually co-sponsoring that bill. And so I can let you know, I'm gonna give this sister the mic because I feel it in my heart that she needs it.
Thank you, Kim. Thank you, Kim.
Hello, Rhonda and everyone else. I am Stacey Anderson. I'm representing NACRO, National African American Civil Rights Organization, the Honorable President Betty Williams. But what I wanted to say, it's very important. Right now, at this time in Sacramento, there is a young lady, I'm emotional, that Justice for Jordan, Monique Bridges, they're in court right now. And over a bad situation that happened where her baby was born, brought out with biceps, crushed his skull, brain bleeds, coded. And what I want to talk about or bring, and also get the question, accountability. Accountability when it comes to these hospitals. Right now, her case has dwindled from her body being ripped apart to the baby. He's alive, thank God, by a miracle. But she's out of the court case, her trauma, and also the hospital has been set out of it. So it's just the doctor. And all of these injustices is what you guys are all speaking about today. And I told her, because this is the only reason why I'm not at court with her, to be by her side, is I told her I would come and be a voice for her when she couldn't be a voice here for herself. So the question is, what do we do about accountability and the strong atrocities that are built around when this does happen? And Adjoa, how you said about the 2 families and the deaths. Well, Monique and her baby is still alive, but fighting. How do they fight? How do they get represented correctly when lawyers are selling you out and there is no justice? What about that?
Well, I have to get Michelle's information from Consumer Watchdog. Consumer Watchdog, Michelle, I can't think of her last name right now, really comes out and represents. I remember we went to Kern County in Bakersfield, Dr. Franklin and I, a couple of years ago. Actually, Senator Cuevas, Smallwood Cuevas, asked us to come and speak. And we've spoken to this issue. I have not heard back from the board. We don't know what are the next steps. So it sounds like we need to really work with the Medical Review Board, because a lot of the doctors and nurses are giving like a little slap on the wrist, if anything, and they keep on doing negligent care. So it sounds like, I don't know if there's policy. I mean, it feels like it's already been done, but what do we really do to make folks be accountable? Because then there's also still additional, if that child, because I have a special needs grandchild, if that child has special needs, that's still a cost to our system. So if we could work on prevention and intervention, we wouldn't continuously be in these situations. So I don't know, that sounds like maybe something up next for CB.
Thank you. Anyone else want to comment on that before we wrap up?
My favorite place to bring accountability is the newspaper. I find that shame is a very powerful motivator, but it's also your motivator of last resort. So you got to try everything else first because they're not going to be your friend when you bring the shame. But I like to work in the newspaper or other very public spaces to bring accountability because I think that that's part of the challenge is that there's not a lot of accountability in this system, which is why we're where we are at. And so I think it's up to us as community members to use the levers that are available to us as community members to bring accountability. And so my strong recommendation is to look at the Sacramento Bee, see who has written about Black maternal health in the past, and then start to reach out to those reporters directly to say, I've got this story for you. That's what I like to do.
Great. Thank you. So I just want to wrap up the panel discussion with a question that I would like for each of you to respond to. And so what would be the message that you would like to leave with, deliver to policymakers today about possible fixes or solutions to really make an impact in closing the gap in Black maternal health outcomes? So Dr. Chambers, we'll start with you at the end of the table.
I would say as all of these amazing bills are coming out, that I would love to see alongside them investment in community-centered research for us to be able to answer these questions. Not only how do we hold, people accountable who we're gearing the bills towards, but also what additional community resources are needed by the story that just came up.
I would just say as our state grapples with the cuts that are inevitably headed our way, really making sure that we are centering this population and Black and other Indigenous, Pacific Islander, pregnant and postpartum individuals is going to be critical if we don't want to backslide.
I would like to say that we can't keep doing the same things and expect something different. We have been having the exact same public health approach in this state for over 30 years, and over those 30 years, we've seen the disparities widen, we've seen the outcomes get worse, it's not getting better. And so most of our interventions, public health interventions to improve pregnancy in California are really kind of rooted in a model around educating people out of disparities. But I hope that if you've learned one thing here, you can understand that the issue is not that there's something wrong with us Black moms. There's something wrong with the systems in which we're supposed to be giving birth. And so I think that we need to move away from so many education-based interventions, which is what the majority of our public health interventions are kind of rooted in, and get into a space where we can be creative and trying something that really works at the upstream structural level.
Thank you. There's so many ideas running around in my head right now, but I'm a very community-oriented person, and I participated in a podcast about a week or so ago around advocacy. I would love to see just an army of advocates developed, trained, taught on what their rights are, what they can do, who they can go to, and how to get those stories to the media. I think it's critical. That's the part of that shaming is exposure, and I think the folks on the ground that are actually experiencing some of these things and some of these issues are going to be the best voices for getting that information out there. So I'm for the army of advocates.
Thank you for that. I think for me, I start with saying stop ignoring the truth. It's sad that what we are coming to in this nation is a denial of 400 years of the truth. Racism is a problem in this nation. We cannot deny that. We have enough data and facts to support it. I was very grateful to Dr. Ferrer, our public health director, when she first shared that in 2017, when they were establishing the Center for Health Equity, that racism was the leading cause of infant mortality, Black infant mortality. And that was the first I had heard a public health leader say that in my over 20 years of working there. So to me, it would be very imperative to support work, just like what Sandra said, in the establishment of a community action team a 50-50 partnership between community and government. We've been able to bring those with the lived experience as well as those doing the work. Let's not be impractical here. We have to be more than just analytical, but really practical to what is happening to folks and hear from them on the services, what works well for them. We enrolled 410 women in our guaranteed income program. I'm excited. My abundance coaches have been doing great work, and we have also found out what are the needs of the clients. Pelvic floor therapy, financial literacy. We just did a Let's Talk About Sex conversation, bringing men and women together to talk about communication and healthy sex, as well as the pregnancy and postpartum journey. And so it's just been an exciting journey, but I think setting a significant amount to what is actually needed annually to improve these pregnancy and birthing outcomes, funding that is sustainable and that does not go away. This is not going to be resolved in 5 to 10 years because it didn't happen in 5 to 10 or 20 years. And so that's what we really need, and that's what I would look for policymakers to do and set forth. Thank you.
Thank you very much. So I started out talking. You want to go ahead? I started out talking about, this is Black Breastfeeding Week, and the theme for this year is boots on the ground, right? And so I think some of us may have danced to that song, but I think as we are facing what is coming down the pike for the next 2 years, having more boots on the ground, more advocates, more community-based and focused and generated solutions to compensate for some of the things that we are losing as part of the change in the infrastructure that we're going forward. So I thank you all for being so amazing and brilliant, beautiful women who are doing amazing work and making a difference in the community to really help change outcomes for Black women and Black babies. So please, can you give them another round of applause? Thank you. And so in addition to you all for being here and the panelists, I'd like to thank Dr. Weber Pierson, who had to leave early. Thank you to my team and volunteers who helped support the event today, and also to our sponsor for making it possible today. So just a couple of housekeeping things. If you want to stay in touch with us, keep up with what we're doing, you can follow us on social media, mostly at YourCBHN. You can join the Campaign for Black Health Equity to support the work that we do so we can continue to do the work that we do. And so please sign up. You can become a member as well of the Black Health Network. We do a lot of member events across the state that are in person to connect and collaborate and bring people together so that we can not work in silos but work more collaboratively as we're addressing some of these issues. And then please, please, please take a box lunch on your way out. So there's probably extras. So there's stuff for vegans, stuff for meat eaters, stuff for everybody. So please do that on the way out, and just want to say thank you all for being here today. I really appreciate your support and being here throughout the whole session. So thank you so much.
Thank you.